This lecture is going to talk about your muscular system and all of the muscles that you have in your body. It is part and parcel of the musculoskeletal lecture. So when you're done with this, if you haven't listened to the skeletal system, definitely spend some time there. You'll see a lot of overlap between the two of them. Here are our objectives for this lecture. As always, if you're comfortable with these, you should do very nicely on the quiz that we'll have on this. Some combining forms here that refer to muscle. You will see both myo and musculo used to refer to muscle. Myo is a little more common. When we get to the cardiovascular system, we will talk about the myocardium, or the muscle of the heart. Our combining form ino refers to a fiber, and fascico to fascia, both of which we will talk about a little more in detail. Anything with teno or tendino refers to tendon. Do not confuse this with tono, which refers to tone, like muscle tone, if it is strong or weak. Ergo, you've probably seen before if you have like an ergonomic keyboard or an ergonomic chair or an ergonomic mouse, whatever it may be. Ergo refers to work, and then anything with kin or kine in it is talking about movement. If you go to school to study kinesiology, you are studying how the body moves. Now, if you remember from lecture number 2 2 weeks ago, there are 3 types of muscle in the body. When we talk about muscle, usually my students latch onto like skeletal muscle. Think Charles Atlas, the meatheads in the gym pumping iron. And that is a form of muscle, but there are 2 other types as well, smooth and cardiac muscle. Smooth muscle you also hear called visceral muscle. Your viscera are just your organs. So visceral muscle is found in your hollow organs and in ducts. What's a hollow organ? This would be something like your stomach, your intestines, the bladder, to a degree, some smooth muscle in the trachea, the uterus. These are all hollow organs, and you'll find varying amounts of smooth muscle in them. Smooth muscle is an involuntary muscle, which means you have no control over when this muscle works. You can't say, okay, intestines contract, which is great, because if you did have to think about this, you'd probably die in your sleep. Smooth muscle has this interesting kind of wave-like contractions that we call peristalsis, and I will post a couple of videos of peristalsis in action. It's a little wild. So that's visceral muscle or smooth muscle. Cardiac muscle is the other type. Cardiac muscle is only found in the heart. We don't find it anywhere else in the body. Also involuntary, which is really good, because if you had to control your heart beating, you would die every time you went to sleep. Skeletal muscle is the muscle type that we're going to spend the most time talking about today. Skeletal muscle attaches to your bones. It pulls on your bones, and that's how you get movement, specifically voluntary movement. If I tell you right now, raise your right arm, you can do that. I can't tell you, hey, make your stomach contract. That won't work. Now, just because something is voluntary doesn't necessarily mean that when it's moving because you're telling it to move all the time. For example, if you have your diaphragm, for example, that sits underneath your ribs, underneath your lungs, that is the muscle that helps you breathe. You have been sitting here listening to this lecture, breathing on your own, I hope, without really thinking about it all that much. But if I tell you, okay, take a deep breath in, imagine you're the doctor, they're listening to your lungs, and then take a deep breath out, you can do that as well. So just because you're not controlling it doesn't mean that it's not a voluntary muscle. The muscles that control your eyelids blinking are more involuntary muscles, and now you're thinking about how many times you're blinking your eyes. You normally don't think about that unless I tell you blink once for yes and twice for no, or unless you have something in your eye and you're trying to blink very hard. But normally you don't think about how often your eyes are blinking. That just happens on an automatic basis. Your skeletal muscles are responsible for your posture. A lot of the muscles, especially in your back and in your hips, are just responsible for keeping you upright. And then most of your body heat comes from your skeletal muscles contracting. Think about if you go outside and start shoveling snow during a blizzard. It's very, very cold out there. Eventually you will warm up because you're using your skeletal muscles and contracting your skeletal muscles. So this is an example of how your muscles are kind of constructed. Muscles start with one tiny little fiber, one cell. They're long, thin little cells, and a bunch of these cells are all bound together by this connective tissue called fascia into a fascicle. And then you get a bunch of these little fascicles that bind together and are wrapped around by fascia that form a whole big muscle. These little fascicles, all of these tiny bundles of muscle cells in the muscle, this is what allows you to have varying degrees of strength in your muscle. This is why you can use your arm to pick up a really heavy bucket full of water, or you can use it to pick up a pencil. When you recruit more of those little fascicles, when more of them contract when you're doing work, that's what gives you more strength. If you're picking up something that doesn't need a lot of strength, like the pencil, you'll maybe use one or two of those fascicles. Tendons hold muscles onto bone. All muscles have a tendon that has them attached to a bone. I would know that for the quiz. That right there. We are not going to get super detailed into how the nervous system runs your muscles because it is really detailed, but your muscles are stimulated by these little motor neurons. These guys right here that run the nervous system. And they run the nervous system by releasing this neurotransmitter called acetylcholine. You see it abbreviated sometimes ACH. Acetylcholine triggers a contraction of the muscle, and this is done by these two little proteins called actin and myosin. You don't need to know a lot about them, just know that they help to contract the muscle and pull it together. What would be good to know is that you need both ATP and calcium for muscle contraction. Usually when we think about calcium, you think about building good, strong bones or teeth. But calcium is crucial for muscles as well. Calcium is what helps your muscles contract. ATP helps your muscles relax. And actually, when you die, when your body goes into rigor mortis and it gets very stiff and unmoving, that's because you've used up all your ATP and you don't have any more ATP to make your muscles relax. Muscles work together at a joint to make movement, and a muscle that causes contraction is called an agonist. A muscle that causes relaxation is an antagonist. A synergist works with the agonist to make contraction. An antagonist here, hopefully you see the prefix anti, an anti-agonist. We drop the I because agonist starts with an A. The point of origin is the place where a muscle begins, the stable part where it starts on the skeleton. The muscle doesn't make any movement happen at the point of origin. The point of insertion is where the muscle actually causes movement. So if we look at an example in a little bit, this is showing the neuromuscular junction. So a neuron coming down and innervating a muscle cell and then releasing acetylcholine to trigger an electrical signal here. Here we go. So if we look at an example of a muscle, let's look at your brachialis. Your brachialis is a muscle in your upper arm, this guy right here. And this is the primary muscle that lets you flex your forearm and bend your arm up. The brachialis point of origin is along the humerus right here. And it doesn't do any movement right there. Its point of insertion is down here along the radius, and that's where it causes movement. So that's what we mean by origin and insertion. Your biceps also helps you contract your forearm. Your biceps point of origin is way up here underneath your scapula at the top of your shoulder blade. The point of insertion is down here on the radius. So your origin or your bicep doesn't move your shoulder up here at the origin. You have other muscles for that. Your deltoid does that. Your bicep moves down here at the point of insertion. It moves your forearm. So hopefully that makes a little more sense. Now, obviously, after you bend your arm, you don't want to walk around with it bent all day long. You want to eventually straighten it back out. And the muscle that helps you do that is your antagonist, which is your triceps, 3 little muscles on the underside of the arm that originate up here on the scapula and the top of the humerus. Their origin is wrapped around the elbow down here, and when that muscle contracts, it pulls and straightens your arm. So hopefully that kind of clears up the idea between an agonist and an antagonist. So in that last slide, you saw a handful of muscles with different names, and we name muscles a bunch of different ways. They are named by where they're found in the body, the direction that the muscle fibers are running, their size, their shape. You saw 2 muscles that had the suffix seps, the biceps and the triceps. You also have a quadriceps in your leg. The suffix seps means head. Think about cephalo from your directional terminology. So that's what we mean when we talk about bi or triceps. And then a muscle is often, you'll see, frequently named by what it does in the body. Your flexor carpi ulnaris is named because it flexes your wrist. You do not have to know all of these muscles. If this was a full-blown anatomy class, you absolutely would. On top of their nerve, their vein, their artery, and their action and their origin and insertion. So fortunately, you don't have to study all that. But a few examples here. The deltoid, which sits over your shoulder, is named for its shape. The Greek letter delta is a little triangle. We have here the orbicularis oris, which is a muscle that surrounds your mouth. Orbicularis means around or surrounding. You see the same thing in the orbicularis oculi, so they're named for the shape that they take. External and internal oblique muscles run at angles along the ribs. You have the adductors of the thigh. To adduct is to bring something close together, so these are muscles that will bring your legs close together. Here's your quadriceps femoris. There's our suffix seps. I mentioned the flexor carpi, that's named for what it does. It flexes, it bends the wrist. In the back here, some other examples. The trapezius is so named because it's shaped like a little trapezoid. We have the teres, both major and minor. Teres means round. These are 2 little round muscles back here on your shoulder. The gluteus, maximus and minimus. Gluteus comes from the Latin word, or the Greek word glaut, which means rump. So that's your rump muscle. And then you have another set of biceps, the biceps femoris, back here in the back of the leg. Down here, this one always throws my students for a bit of a loop. You have the gastrocnemius. And hopefully you look at that and you say, but wait, gastro, doesn't gastro mean stomach? And it does. Good job. You're paying attention to your terminology. The gastrocnemius is so named because it has 2 stomachs or 2 muscle bellies, one on the left here, one on the right. This is the muscle that gives you those wicked leg cramps in the middle of the night. That sends you shooting out of your bed at like 3 in the morning. Some key terms here. Again, I'm not going to read through all of these because you don't want to hear that, but I would spend some time reviewing these for the quiz. These will be very helpful to know. So clinical stuff that we see with your muscular system. A myopathy is any disease or disorder of the muscles. That's what pathy means, just disease or disorder. Stuff that we use to study and diagnose muscle diseases or disorders. You can look at the way that the muscle is used, look at the person using the muscle and see maybe that indicates where it's been hurt or damaged. Electromyography measures the electricity that's moving through a muscle to make sure that it's working properly. And then you also see this creatine kinase. This is an enzyme that your muscle releases on a daily basis just from regular work. It's a really nice enzyme because this is how we measure kidney function. You should always have a steady amount of creatine kinase in your patient's urine. But if you have damage to the muscles, you'll suddenly see a whole bunch of creatine kinase released sort of all at once. You see this sometimes when people are, say, in a really bad car accident, they get beat up really badly. More concerningly, there have been some cases in the news in the past few years of really bad child abuse where a child is badly beaten to the point where they release a bunch of creatine kinase and they go into a condition that's called rhabdomyolysis. So your kidneys can handle a little bit of this stuff on a daily basis, but they can't handle a huge wave of creatine kinase. And if they get overwhelmed by creatine kinase, that damages kidney function and they start to shut down. Your patient with rhabdomyolysis then will be having all kinds of issues with their kidneys. They'll also have this very, very dark, almost brown urine. Usually they'll need to go on dialysis for a little while. Muscular dystrophy is a number of hereditary muscle diseases that cause progressive weakness of the muscles. The one that we're going to talk about because it's the most common is Duchenne muscular dystrophy. This is progressive, just wasting away of the muscles. They're not inflamed. The muscle tissue just gets wasted away and replaced with connective tissue and fat. So you see a lot of weakness in these patients. Initial symptoms of muscular dystrophy start fairly early in life, between about 2 to 3 years old. Prior to being about 2 to 3 years old, your patient will look really normal. After that, you start to see some pretty profound symptoms, and I will link a video that shows some of the symptoms that you see of muscular dystrophy, of Duchenne muscular dystrophy. So you'll see your patient will have really bad balance, they'll fall a lot, they'll have this kind of unmistakable waddling gait. They hold the shoulders back, they walk on the tiptoes because the muscles of the calf are too tight for them to put their heel down to the ground. Really hard to get up from a lying or sitting position, especially if they're on the floor. And the technique that you use to get up if you have muscular dystrophy is called Gower's sign. And I'll post a video of that as well. And then really bad muscle pain, stiffness, weakness. Duchenne muscular dystrophy specifically affects almost only boys. If you ever see a patient with Duchenne muscular dystrophy, they will be male. They have a very short lifespan, only 25 to 30 years. And this is because, and I want you to think about this as we talk about all of our diseases of the muscles, if all of your muscles are wasting away and getting weaker and being replaced by fat and connective tissue, what other really important skeletal muscle is also wasting away and getting weaker and getting replaced by fat and connective tissue? Hopefully you're thinking of your diaphragm, which, remember, is the big sheet-like muscle underneath your ribs, underneath your thorax, that helps you breathe. And if that is wasting away and getting weaker and getting replaced, you're not going to be able to breathe as well, you're not going to be able to cough very well, and quite often what will finally kill a patient with DMD will be pneumonia. Because they aren't able to breathe well, they aren't able to cough well, they become very susceptible to lung infections. Sometimes you'll see cardiomyopathy issues with the cardiac muscle. Sometimes you'll see mental impairment with DMD, but it's not uncommon to see a patient with Duchenne who is mentally and otherwise physically very sound, except for their muscles wasting away. This is Gower's sign up here. A child with Duchenne getting up off of the floor is going to push themselves up into kind of this downward dog position, walk their hands backwards on the carpet, and then push up on their knees to pull themselves up into a standing position. This is kind of a classic, unmistakable sign of Duchenne. You can see here the walking that you commonly see with Duchenne, holding the shoulders way back, walking on the tiptoes because the heel, the muscles of the calf are very tight, very sway back, because the muscles of the abdomen and the muscles of the back are very weak. So why boys? Why does Duchenne muscular dystrophy only show up in boys? We'll look a little bit at the inheritance pattern of DMD. Duchenne is an X-linked recessive gene. And this tells us two things about the gene. One, this X-linked part tells us that Duchenne muscular dystrophy is found on the X chromosome, one of our sex chromosomes. The recessive part of the gene you saw when we talked about albinism earlier. Recessive means that you need 2 copies of the gene in order to be affected. If you only have 1 copy, you're a carrier. You have the gene hiding in you, but you're not actually affected by it. Okay, so then what does this look like practically? XX, XY, which one is male, which one is female? So female is XX, women have 2 X chromosomes, male is XY. And if we have, so let's start throwing in broken chromosomes. So here's our Duchenne muscular dystrophy. Each of our patients here has a copy of the gene on their X chromosome. Our woman over here, she just has this 1 copy of the gene. Our gene over here, we'll write a capital D. This is a good gene. It's not broken. It's just healthy. So she is going to be a carrier because she doesn't have 2 copies of the gene. You need to have 2 copies to be affected. What about him? He only has 1 copy of the gene. Is he a carrier? Does he have a second backup copy like she does over here, right? This is our backup, our good gene. No, he doesn't have a backup. All he has is this Y chromosome right here. The X and the Y chromosome are not the same. The X chromosome is really big. It has a lot of stuff on it. The Y chromosome is pretty small. It has the gene for how to make a testis and, according to an old professor of mine, the gene for how to back up a trailer. He never told me where that gene was found. But that's it. That's all that you have on the Y chromosome. So he doesn't have a backup. Whatever he has right here on this X chromosome, that's what you're going to see. So even though he only has 1 copy of the gene, he has Duchenne. Hopefully that makes sense. If not, come see me during office hours and we can talk about it a little more. Okay, so then, but why does it only show up in men? Obviously, men are going to be affected more by it, but, you know, don't you have an equal chance of getting an X chromosome from mom or from dad? And we'll take a little look at that with a Punnett square. Punnett square is just a simple genetic tool. This is how you determine what your possibility of genes will be when you're looking at 2 people having babies. So over here on the left, let's put mom. Mom can give you an X chromosome, and that's it. She has 2 X chromosomes. It's a 50-50 split, which one you get from mom. From dad, you have a 50-50 chance of getting his X chromosome or his Y chromosome. So let's say they start having kids. Again, there's a 50% chance you'll get X chromosome number 1 or X chromosome number 2. That's all you're going to get from mom. From dad, there's a 50% chance that you're going to get his X chromosome and a 50% chance that you're going to get his Y chromosome. It's the male that determines the sex of the baby. The female has very little to do with it. Okay, so let's say then mom is our carrier from earlier. This X chromosome, she's got that Duchenne gene on it. That means that on that gene, or on that chromosome, she's passed that Duchenne muscular dystrophy gene to those 2 hypothetical kids. So they have a 50% chance of getting that bad chromosome, a 50% chance of getting the good chromosome. Here we have a daughter. She's going to be a carrier, just like her mother. But what about our son here? He only has one copy of the X, so whatever you see on that X chromosome is what you get. So he's going to have Duchenne muscular dystrophy. And this is the inheritance pattern that we see with all X-linked recessive genes, and there are a bunch of them. Color blindness, red-green color blindness works the same way. What we see with an X-linked recessive gene, that it gets passed from mother to son down that line. He didn't inherit that from dad. Dad's X is clean. He doesn't have DMD. He inherited that from his mom. Okay, but hypothetically, let's go crazy and say that dad had this Duchenne muscular dystrophy gene as well. Right? We'll give him a broken X as well, because we can. So in the child that inherits that broken X, here's our daughter, here's another daughter, is this X going to pass to his son? No, because to be a boy, you have to have a Y chromosome. He passes the Y chromosome on to his son. He passes his X chromosome on to his daughters. So hypothetically speaking, I know this is getting very messy, hypothetically speaking, if our man was also affected with Duchenne muscular dystrophy, he would pass on that broken X chromosome, but he would only pass it on to his daughter. And now, instead of being a carrier, his daughter would actually have DMD in this case. His second daughter would be a carrier. And hopefully this explains then why we see the inheritance pattern that we do, why this goes from mom to her son, not from dad to her son. Okay, but Ms. Catherine, why doesn't this happen? Why don't we see a bunch of daughters running around with Duchenne muscular dystrophy? Right? Because if in theory we could see, a man with a broken X chromosome passing that on to his daughters, why doesn't it happen in real life? And for that answer, you need to get really practical. What is the lifespan of a man with Duchenne muscular dystrophy? About 25 to 30 years. Is he going to live long enough to have kids? No. And by the time he is old enough to have children, he's going to be very, very capacitated and not be able to. So this is why we don't see women running around with Duchenne, because they don't have a father who has the gene. Hopefully this clears up a little bit why we see this only in men, and the inheritance pattern behind it. I wouldn't be familiar with this for the quiz. Where does that boy get his X from? Does he get it from mom or from dad? And again, if you have questions about this, because genetics can be a little tricky, drop by and see me during office hours. Okay, moving on from muscular dystrophy. Polymyositis is inflammation of the skeletal muscle. The prefix poly in this means multiple or many or lots. So polymyositis is kind of a systemic inflammation of all of your skeletal muscle that leads to lots of weakness, issues with dysphagia. DYS, means difficult or painful. Phagio is swallowing. So difficulty swallowing is dysphagia. This is bad because you don't want your patient to choke. You also sometimes see cardiac problems in a patient with polymyositis as well. The cause of polymyositis is not really well understood. Right now, the possibility of viral infection that leads to this polymyositis, that's kind of where we're leaning. And that seems to be currently the diagnosis du jour. If we have a weird condition that we don't understand, we don't know where it comes from, it's probably a virus. Right now, actually, the big virus that's in question is, it's spelled with a CK, Coxsackie virus. That's kind of, we don't know what it is. It's probably Coxsackie virus. We do know that you tend to see some issues with autoimmune disorders associated with polymyositis. Hopefully you remember what autoimmune is from the integumentary system. That's when the body's immune system starts to attack the body. And this autoimmune thing has some merit to it because you often see polymyositis with either rheumatoid arthritis or lupus, both of which are autoimmune diseases. Sometimes you'll see the skin involved in polymyositis as well. Your patient will have this kind of reddish purple rash. You diagnose polymyositis with different enzyme studies looking for damage to the muscles, creatine kinase like we talked about earlier. You may do a muscle biopsy. Fibromyalgia syndrome, kind of similar to polymyositis. You see widespread muscle aches and tenderness and stiffness and pain, sometimes also sleep disorders. There's no real case definition for fibromyalgia. It can be very difficult to diagnose. I mean, widespread muscle aches and sleep disorders, that sounds like, this week I'm not sleeping very well or something like that. There's also no real solid treatment for fibromyalgia either. Exercise, we know, can help with it. Muscle relaxers, pain medications can help as well. Chronic fatigue syndrome's kind of similar to polymyositis and kind of similar to fibromyalgia. This is just persistent fatigue. And all of you are like, oh, I have CFS, I'm tired all the time. But persistent fatigue with no known cause, not persistent fatigue because I'm working and going to school and, I don't know, stayed up last night for 3 hours on Netflix. Other signs that you see with chronic fatigue syndrome, sore throat, painful lymph nodes, muscle and joint pain, headaches. What does that sound like? It sounds like a viral infection. It sounds like the cold or the flu. And again, this is another condition that they're looking at, that maybe you get infected with a virus and it changes the way that your cells look, and now your body doesn't recognize your cells anymore. It thinks that they're foreign, so it starts attacking them. There's no really consistent treatment for CFS, and again, it's very, very poorly understood, which can be terribly frustrating for your patient who has cystic fibrosis, who has chronic fatigue syndrome. Myasthenia gravis is another autoimmune disease. In myasthenia, we see our root word myo, which means muscle, and then asthenia means weakness. So weakness of the muscles. You see this mostly in the face, and it usually tends to be unilateral. You see it on one half of the face. The other half of the face is pretty well, and then on one half of the face you'll see the eyelid will droop. It might not even open. Your patient might not be able to open their eye all the way. You see the corner of the mouth will droop. Sometimes myasthenia gravis will go away. Sometimes you'll be stuck with it kind of for the rest of your life. There's not really a cure or a treatment for it. ALS, or amyotrophic lateral sclerosis, is called Lou Gehrig's disease more commonly. Any of you do the ice bucket challenge? It was really big, like 4 or 5 years ago. Usually I have at least one student in class who's like, yes, I poured ice water down my underwear. Good for you. Lou Gehrig's disease is progressive breakdown, not of the muscles, but of the nerves that innervate the muscles. And that leads to wasting away and atrophy of the muscles. The cause of ALS is not well understood. There's a very, very small percentage that we can find genes that cause ALS, but for the most part, it just kind of crops up out of nowhere. We do know that if you have had repeat TBI, if you've had a repeat traumatic brain injury, that significantly increases your risk of a whole bunch of things. ALS, Parkinson's, Alzheimer's, all sorts of stuff. And how do we know that? What's our population that has repeat traumatic brain injury that we figured this out on? And we figured this out on hockey players, on football players, the NFL especially. People started to notice when you did autopsies on football players who had died, years after they'd been playing, there's a lot of brain damage to these patients. Obviously, this led to the big issues with cover-up and suit because people were being told that, what we're providing for our football players is safe when it wasn't safe. This is still an ongoing debate. Signs that you'll see of ALS usually starts with weakness and cramping and twitching in the extremities, in the hands and in the feet. Life expectancy after you're diagnosed with ALS is 2 to 4 years. It's a long time to live with a very debilitating disease that just kind of slowly wastes you away. It's a pretty rare disease. There are only about 5,600 diagnoses in the US. You usually see it later in life, and I think it's more common in men than it is in women. So for those of you who did stand outside and get ice in your underwear, they raised several $1 million, I think, for the Ice Bucket Challenge for ALS research. And they actually found something. They found this NEK1 gene, that's this little white stripe right here, that's found on chromosome number 4. And this is a gene that you see in some inherited cases of ALS. So all that research, all that money, all that very cold water going down your shirt, you actually found something with that. That's pretty impressive. It probably also says something about how we do medical research in this country, but we found something, and that's the important part. Stress injuries to a muscle include things like accidental injury, overuse of a muscle, repetitive motion if you're doing the same motion over and over and over with a muscle. There are different types of injuries you can see to muscle. You can have a strain, which is tearing of the muscle, inflammation, you've used the muscle too much. You go out for a hike and the next morning you wake up and you're all stiff and sore. That would be inflammation. You can tear the ligaments that hold your bones together or the tendons that hold your muscles on your bone. Bursitis. A bursa is a little bag of fluid, almost like a glorified water balloon, that sits near your joints where you have lots of bones that come together, and it keeps them from rubbing against each other. You can see inflammation of that bursa as well. Tendinitis is inflammation of the tendon or the sheath of the tendon at a joint. Signs that you'll see of this: pain in that joint, fatigue, weakness, the joint's very stiff, and you're not able to move that joint as much as you would. You lose a lot of your range of motion. Treatment for just about any stress injury is our classic RICE, right? Rest, ice, compression, and elevation. If it's pretty severe, you might put on a brace. There might be medications that you can take to decrease inflammation and to decrease pain. If it's a very severe stress injury, you may be looking at things like a steroid injection to help with inflammation. Ultrasounds will help to bring more blood to that area, so that will help as well. Strength training through physical therapy, surgery, all of that's possible. There are some common injuries to the upper extremities, the arms and the hands, that we'll take a look at. Rotator cuff injury occurs when you tear the tendon of the supraspinatus, this tendon right here. This is on the front of the scapula, and it causes the shoulder to kind of pop forward a little bit. Kind of painful. Sometimes will heal on its own. If you've completely ruptured the tendon, you may need to go in and have it surgically fixed. Carpal tunnel syndrome occurs when you see inflammation of the transverse carpal ligament, this guy right here. You see this a lot in people who type a lot because they're constantly moving that wrist, and that can cause inflammation of that ligament. As that ligament gets inflamed, it causes pressure on the little median nerve right here, and the median nerve innervates primarily your first 3 fingers, your thumb and your pointer finger and your middle finger. So your patient with carpal tunnel syndrome will have lots of tingling and kind of a buzzy feeling in their first 3 fingers, kind of very similar to when you sit on your leg and your leg goes numb. It can also be very painful in those fingers as well. Trigger finger occurs when you get inflammation of a synovial sac, and that pulls and tightens on the tendon and causes the bones of the finger to bend. And then tennis elbow or golfer's elbow is inflammation of the tendon that holds your carpal muscles onto your humerus. You see inflammation and pain there. Common stuff that you see in your lower extremities: hamstring sprains or strains are not uncommon. Your hamstrings are the muscles, the 3 big muscles in the back of your leg. A shin splint occurs in your tibial muscles along the inside and the outside of your lower leg. This has nothing to do with the bone. A lot of the time people think, oh, I have a shin splint, I must have cracked a bone. No, you just really made the muscles in your calves mad. And then you can see inflammation of the Achilles tendon, which is this tendon right here that holds all of your muscles down onto your heel. Inflammation of that would be just tendonitis. It is possible to rupture the Achilles tendon, and if that happens, that results in a very major complicated surgery to pull that Achilles tendon back down to attach it to the heel. Fortunately, you have to try really hard to rupture your Achilles tendon, so probably you guys are all safe. Last thing that we're going to talk about with the muscular system is a kind of interesting, kind of horrifying infectious disease. This is a painting by Sir Charles Bell. He's a painter that followed around the British Army in the late 1700s, early 1800s, when they were waging their wars all over Europe, as the Europeans were wont to do during that time. And he painted a lot of what he saw in the patients that the doctors were treating from the front lines when they would bring them in. And in this painting here, we see a patient who's in full tetanic contraction. He had gunshot wounds that got infected. He developed tetanus, and you can see he's having really bad muscle spasms. That's why his back is arched the way it is. You can see his fists are clenched. You can see his jaw is clenched as well. The real tightness in the arm muscles right here. This is not pleasant. Think about the last time that you woke up in the middle of the night with a wicked Charlie horse in the back of your calf. You're in bed, asleep, drooling on your pillow, maybe spooning the dog, and then all of a sudden you're up and maybe screaming and running into furniture. Now imagine that kind of cramp, but all throughout your body, and not just once, but lasting for days up to weeks. Tetanus is unpleasant, to put it mildly. Tetanus is caused by this bacterium Clostridium tetani, and tetanus lives in dirt. It lives in the soil. So think about what we talked about with smallpox. Could we ever eliminate tetanus the same way that we did with smallpox if it's found in the soil? No, we could vaccinate everybody against tetanus, but if it's still just hanging out in the dirt, there's no way we could get rid of it the same way that we do smallpox. It gets into the body through contaminated wounds. A lot of the time you hear people talk about, I stepped on a rusty nail, now I have tetanus. It's not the rust itself that you're concerned about, but any dirt that might be on that nail. Interestingly, most cases of tetanus don't come from I stepped on the rusty nail. Most of them are just, I got cut and scratched and got some dirt in that wound and didn't even think about it. Think about all the tiny little cuts that you get on your body in a day. And then imagine getting dirt in that. That's usually where a tetanus infection comes from. The incubation period for tetanus is about 3 to 21 days, 3 days to 3 weeks. What is an incubation period? We're going to see this term a lot as we go through some of our infectious diseases. So incubation period refers to the time between when you get cut, you step on that nail maybe, and you start showing symptoms. So from exposure to onset of symptoms. And on average, that's between 3 days to 3 weeks. So I go out hiking with my friends, don't worry, we're all social distancing, and I fall down and go boom and scratch up my elbow and get some dirt in it, but that's okay, I'll be fine. And then, a week later, I wake up with tetanus. That's what we mean by incubation period. Signs and symptoms of tetanus, very similar to what we just saw in the last picture. Tetanus used to be called lockjaw because it will cause these spasms that cramp the jaw and keep you from opening the jaw. Muscle spasms that you can have that can last, weeks. So think about our poor soldier in the last picture. He's having those muscle spasms, could be up to a month long. These are muscle spasms that are so severe they can lead to broken bones. Sometimes you'll see seizures in a patient with tetanus. Sometimes they'll have trouble swallowing as well, especially with the lockjaw. So let's say then you do wind up in the ER with tetanus. You're having a very bad week. If you show up to the ER with tetanus, the first thing that they're going to do to treat you is give you this tetanus immune globulin. This is an infusion of anti-tetanus antibodies from a patient who has been vaccinated against tetanus. And that's to help jumpstart your immune system to fight off the infection. This is the same technique that they're doing when they talk about therapeutic plasma for our patients who have COVID-19. They're looking for people who have had the disease and recovered to donate plasma so they can give plasma to patients who have the coronavirus because those antibodies will help them fight off the infection. We do this treatment a lot with very severe diseases or diseases that we just don't really have a lot of options for, like coronavirus. We do the same thing if you have rabies. We tried it when there was an Ebola outbreak in West Africa. So you'll get this tetanus immune globulin. They'll treat you with antispasmodic medications to address the seizures, the muscle spasms. You'll get pretty heavy-duty antibiotics to kill off the Clostridium tetani that's in you. Tetanus takes a really, really, really long time to recover. We're talking maybe 4 or 5 months to get over a tetanus infection. And in the US, this has a 13% fatality rate. So 10 people go into the ER with a tetanus infection, one of them is going to die. 100 people go in, 13 of them are going to die. That's really high for an infectious disease in the US. And that's with all of our access to medication and treatment and whatnot. Imagine what the fatality rate would probably be in middle of nowhere Sudan. Probably 100%. This is a lethal bacteria. Now, as with most things, the best treatment is actually prevention. We do have a vaccine for tetanus. This is the T in our Tdap vaccine. It was developed in 1924. It was developed because while we took a break between having 2 world wars, scientists were working on figuring out how to prevent tetanus because we lost so many soldiers during World War II who were killed not by gunfire or bombs, but were killed by tetanus. The tetanus vaccine actually doesn't protect you against the bacteria. It protects you against the toxin that the bacteria makes. It gives you immunity against the toxin that Clostridium tetani makes. This is the same thing that diphtheria does as well. Diphtheria is an antitoxin vaccine. It is 100% effective. You get your Tdap shot and you stay up to date on it, you will not get tetanus. You get your first Tdap shot month 2, I believe, is the first Tdap vaccine. And then recommended that you have a booster every 10 years, or if you do fall down and go boom and cut yourself up and get dirt in that wound, that would be a recommendation for tetanus. I got a tetanus booster the first time before I went to Uganda because that's a place where you don't want to get tetanus. So yeah, if you get the vaccine, you will be just fine. You don't want to be this person here getting injected with immune globulin. Actually, there was a report not too long ago out of either Washington or Oregon, which should surprise nobody, of a little kid, little 6-year-old kid who had not been vaccinated, got tetanus, and racked up something like an $800,000 hospital bill, was in the hospital for a good 6 months being treated for tetanus. So go get your Tdap shot because you don't have time for that. Here's our little Tdap vaccine. So this is tetanus, diphtheria, which is a respiratory disease, and then acellular pertussis, which is whooping cough, made by Sanofi Pasteur. So that is it for the muscular system. There are a bunch of key terms here, again, that I'm not going to go over because you don't want to listen to me read all of those off. Spend some time reading them on your own. A lot of them are diseases that we talked about. And as always, if you have questions or would like to review or double check anything, drop by at office hours. I would love to see you.